true to Prof Ola Saugstad. But as I remember him, he was a person who had invited the ire of many of us way back in 92, 93, 94, when he, along with our own Siddharth Ramji, started on the project of oxygenating, resuscitating infants without oxygen. And all of us, I too remember, I was also there as a young neonatologist fighting and asking, it's unethical for not using oxygen. These trials were being done in developing countries because it could not be done abroad, and so on and so forth. And for a better say of words, I could say we all have egg on our face today. And reluctantly, we have to accept that one of the pioneering works in resuscitation has been there. And we're very proud to say that Dr. Ramji could today, in my eyes, be considered as one of the pioneering researchers who has really contributed for changes in the way we handle newborn babies. We have Prof Ola. Welcome, sir. I don't think you need too much introduction. And I presume you will bear with me when I said that the initial studies that you did with Siddharth Ramji did attract a lot of criticism by many of us who were the youngsters in the crowd. And today we look back at you as a person who showed us that there's a lot more to neonatology than what we think we know. So I cannot think of a better person to lead us into a very familiar world of delivery room care. I won't take much time. Over to Professor Ola. Thank you very much.
Thank you so much. Just have to get the slide mode. So, yeah, thank you. Do you see my slides? And do you hear me?
Doctor, we can see your too many slides, not the PowerPoint slideshow.
Because I see that.
No. Can you stop sharing?
Yeah.
And then just stop sharing. And can you go to Zoom now? Do you see Zoom? And go to sharing again, and you will see a full screen of that slide.
Yeah, there it is.
Please share that.
Yeah. There. Do you see it?
Yes, exactly.
Now it is. Yeah.
Yeah.
Okay, so thank you for the introduction and thank you for inviting me. And I'm so sorry I'm not present physically in Kerala. I always wanted to go to Kerala. I've never been there. I've been to India many times, as the chairman mentioned. My first visit was in early 90s, and yeah, it's correct what you said, that the study Siddharth Ramji and I conducted published in 1993 was really pioneer work, and many people were really angry about my idea about using air and said it was unethical. But of course, it is very satisfactory to see that today it is accepted all over the world that term and near-term babies should be resuscitated initially with air. Well, this is not the topic of my lecture today. I will talk about delivery room handling of the newborn. And now I'll see if I can change slides. Yeah, here it is. Here are my disclosures. I also have an outline. It's very ambitious, and I don't have time to go into details of all these topics, issues during 30 minutes. But I'll talk about, for instance, there's a very recent European survey about delivery room handling. I've shared some of these data with you. And I will not talk very much about oxygenation. I will go beyond a little bit, beyond the delivery room, and I also talk about hypothermia therapy. I would like to discuss the Helix trial with you, and I'm very interested to hear your opinion about this trial. So this is the ILCOR. I just have to organize so I can see my slides completely. Yeah. So this is the ILCOR algorithm for newborn resuscitation, published in 2010. And at this stage, they introduced the term the golden minute. It was actually Max Venter who a year earlier had introduced this term. And this means that within the first minute of life, every newborn should be taking its first breath. And if it doesn't breathe, it should be helped by positive pressure ventilation. However, the ILCO did one mistake, in my opinion, and they never defined when the golden minute starts. And I talked about this several times before, and when you look into the literature, you see different definitions. As I mentioned here, when the shoulders are out, when the cord is cut, when the baby is on the resuscitation table. But I think today we all agree that we should start the clock when the whole baby is out. And I think this is important because we're talking about the golden minute and we talk about 1 minute APGAR score. We have to know what we mean by that. So what are you supposed to do during this golden minute? Well, the first 30 seconds, you should dry the baby, keep it warm, wrap it in plastic if it's immature, stimulate it to breathe if it doesn't breathe by itself, and position the airways correctly. And you should start to monitor heart rate and breathing rate. And within the next 30 seconds, you should have started respiratory support if that is needed, and also put on a pulse oximeter if that is available. Now, is it realistic to do this during the golden minute? There are several studies showing that this is challenging. And we recently published a very brief overview of some studies, 2 from Tanzania, 1 from Uganda, 1 from Nepal, and to see when the first ventilation with bag and mask was started. And you see this study here from Tanzania, they started after 134 seconds, very late. But this from Uganda after 68 seconds, and Nepal 71 seconds, and again from Tanzania 109 seconds. This shows that it is possible to really start the first ventilation approximately within the first minute, the golden minute, but it is a challenge. Now, of course, there are a number of factors that influence the golden minute, and we have tried to summarize some of these here in this slide, which was on this figure, which was we published in 2-3 years ago now, a summary of delivery room handling, and you can see the reference here in Journal of Perinatal Medicine. So there are a number of factors, antenatal factors or factors during delivery, which affects the outcome. For instance, chorioamnionitis, mode of delivery, antenatal steroids or not, preeclampsia, maternal BMI, or maternal nutrition. And then we have a number of variables we can play with in the delivery room, and we have listed some of them here: tidal volume, flow rate, oxygen, cord clamping, PEEP, surfactant, temperature control, and so forth. And we also published some of the risk factors associated with the need for resuscitation in the delivery room. And I will not go through these in details here, but as you all know, there are maternal factors, and they are listed here, fetal factors and perinatal factors. And it's also possible to identify risk factors associated with intubation rates. And again, we have here the maternal factors, fetal factors, and perinatal factors. Now, I'll talk a little bit about some of these factors, and I will start with the maternal BMI. In 2014, 8 years ago now, we published this study in JAMA showing that there is almost a linear relation between maternal BMI BMI at the beginning of the pregnancy and infant, or here is perinatal mortality. We found this exactly the same relation with infant mortality and neonatal mortality. You see that increases with maternal BMI. We have now continued with this work, and we have now from almost 24 million singleton births, we have constructed this curve, and these data are have not been published yet, so they're not for. It's just for private use in this conference now. But what you see here is that there's a U-shaped curve, and this is for infant mortality, and it seems that that the lowest mortality is when the mother has a BMI between, let's say, 18.5 and up to 25, and then you see it increases like this. And we have looked at different mortalities, not only infant mortality, but neonatal mortality, early neonatal mortality, late neonatal mortality, and post-neonatal mortality. And we find the same pattern as you see here. And also regarding maternal age, we find this U-shaped curve, and also for different races, as you can see here. So one message to young girls or young women is that they should try to keep their BMI around 20, 25 before they get pregnant. What about the use of antenatal steroids? Well, together with Dominique Omo and Nina Modi, we published a couple of years ago a study of almost or more than 38,000 babies born in Europe between 2014 and 2016 with gestational age between 22 and 32 weeks. And what we found in this e-newborn database was that babies who had received a complete course of antenatal steroids had a reduced mortality as expected, but even those who had an incomplete course had a significantly reduced. So the message is that even if you are not able to finish a complete course, you should start when there is threatened premature labor. What about the mode of delivery? Well, this is a figure published by Yi and co-workers some years ago. It shows that mortality, neonatal mortality, decreases until C-section rate is approximately 10%, and then it is stable. So from this data, we conclude that maybe the optimal C-section rate regarding mortality is between 10 and 20%. And I mention this because, as you all know, the C-section rate is much higher than 20% in many places in the world. I guess also many places in India. And this is important also regarding morbidity, and this shows that serious respiratory morbidity is significantly higher after C-section, here for 37 weeks. You see vaginal deliveries, the black boxes. Even up to 39 weeks, there's higher morbidity after C-section. So this is another message that C-section increases morbidity, and it should be kept, should not exceed 20%, perhaps. So what is the need of resuscitation for small babies? And again, the data from the e-newborn database, the European database on babies between 22 and 32 weeks of gestation. And here we can see that for the most immature babies, almost all of them would need resuscitation. but you see that the rate decreases and it's less than 60% at 32 weeks. However, when we talk about basic resuscitation, which is defined as the use of bag and mask plus oxygen, if needed, you see that very few of the immature babies would need that. And it reaches a maximum around 30 weeks, and then it drops a little bit to 32 weeks. By contrast, advanced resuscitation, which means the use of bag and mask, oxygen, intubation, chest compressions, and or adrenaline, if that is needed, you see that most of the immature babies, they would need advanced resuscitation, and the rate drops very significant and rapidly towards 32 weeks. Well, does it matter whether it's basic or advanced resuscitation? Yes, we have found that the risk of death is increased approximately twofold if a baby needs advanced resuscitation compared to basic resuscitation. Now, very recently, the Union of European Neonatal and Perinatal Societies, UNPS, they published a survey of delivery room handling in Europe. And here you see a map of Europe, and you see the black countries here, they contributed a lot and others less. And you see that in this survey, more than 400 units replied. You see that many of these, most of them are from Turkey, Italy, and to some degree Spain, means that the results, the data from this survey comes predominantly from these countries, but we also have some replies from France and Germany, UK, and to some extent from Scandinavia. And I don't have time to go through this, all these data with you. I just want to focus on this survey for those who are interested. But if you look at umbilical cord management after term vaginal delivery, more than 60% of these units, they practice delayed cord clamping, more than 30 seconds after birth, and 23% so-called physiological cord clamping. I'll come back to that. 7% only immediate cord clamping and 5% cord milking. After C-section, delayed cord clamping is practiced in approximately 50% and physiological cord clamping in 30%. And still 25% are clamped immediately after elective C-section. Terminal management, I will not go through that, but just mention a few words about heart rate assessment. Because as you know, ILCOR in 2015, they suggested that heart rate should be assessed by ECG, and they didn't mention stethoscopy anymore. So what is the situation in Europe according to this survey? 78% use stethoscope for heart rate assessment. 32% can use ECG, and 24%, I was surprised about this high number, still use umbilical cord palpation. And yeah, so this, I'm not spend more time on this because there's a lot of data in this survey, and you can find the publication here in Neonatology this year, early this spring. Well, you can find the level of CPAP, level of PEEP, initial peak inspiratory pressure, use of sustained lung inflation in these European countries. And for instance, talk about sustained lung inflation, 61% never use it, but there's some units are using sustained inflation, 16% occasionally and 11% routinely. And I was surprised when I saw this data. So to talk more about heart rate assessment at birth, I mentioned that ILCOR in 2015 suggested that heart rate should be assessed by ECG. And the reason for that is that heart rate by auscultation has been shown to be inaccurate, and it underestimates the heart rate obtained by ECG. But to compensate for that, together with Roger Soule, we suggested that instead of counting 6 seconds, we should count 10 seconds. And maybe some of this inaccuracy could be eliminated. We know that a reliable heart rate is obtained earlier with ECG than with pulse oximetry. In one study, it was 84 seconds difference. On the other hand, many of the ECG signals are excluded due to technical problems. And in one study, up to 40%, which is a high number. And we also have a number of so-called pulseless electrical activity, and animal models have shown up to 50% could be that. So also ECG has some drawbacks, but we know that new devices are under development, and very recently Kateria, he and his colleagues, they published a new study showing that ECG with new technology is very efficient. But in 2016, Roger Soule and I, we stated that auscultation is still the gold standard for assessing heart rate at birth. I would like to hear your opinion about this. And then a few words about delayed cord clamping. I think all the big societies today, they recommend delayed cord clamping, at least for preterm infants. For instance, WHO, they state that in newly born term or preterm babies who do not require positive pressure ventilation, the cord should not be clamped earlier than 1 minute after birth. And the reason they say 1 minute is that we know that after 60 seconds, approximately 70% of the blood volume transfused from the placenta to the baby has reached the baby. And it's not so much to gain if we wait another minute. It's from 70% to 80% something. So I think that's the reason for the cutoff of 1 minute. But of course, now we have also been familiar with the term physiological cord clamping, means that you should start ventilation before you cut the cord. And the reason for that, this is based on several studies, but maybe most of all from an experimental study from Stuart Hooper's lab in Melbourne, Australia. And what you see here is that here we have the arterial pressure. And if you clamp the cord before you start ventilation, you see that the arterial pressure increases quite abruptly. And also carotid arterial blood flow increases. By contrast, if you start ventilating and then clamp the cord, you have this more smooth transition, both in arterial blood pressure and in carotid blood flow. Are there any risks of delayed cord clamping as overtransfusion, symptomatic polycythemia, jaundice, hypothermia, persistent pulmonary hypertension, delayed resuscitation? Well, Bruckner and co-workers, they answered these questions recently, and they suggest that delayed cord clamping in healthy term infants for at least 60 seconds in high income environments and for at least 180 seconds in limited resource environments. And they claim that delayed cord clamping reduces incidence of anemia and iron deficiency. And I think that has been very well documented. It improves hemodynamic parameters, and there is no evidence that delayed cord clamping results in high rates of phototherapy. Now, what about growth retarded and monochorionic twins? Well, they say that more evidence is needed. Very recently, there was a Zoom meeting about this matter with Kateria, Ola Andersson, and Arente Paz. And I brought up this question about monochorionic twins, and they said that, yes, today they practice delayed cord clamping also for monochorionic twins. And I think it is important to be aware that if you practice delayed cord clamping the oxygenation pattern is different from if you practice early cord clamping. So this is illustrated here. This is in a paper by Sankaran and Lakshmin Rushma and myself, which is in press, I think. I think it's not been published yet. And here we have the situation here to the left in the fetal life. And you see if we have early cord clamping, cardiac output is decreased, and there is an increased risk for intraventricular hemorrhage. You see that the oxygen saturation is lower. It increases slower than if you practice delayed or deferred cord clamping as seen here. The cardiac output is higher and there's less intraventricular hemorrhage, and oxygen saturation increases faster. And this is demonstrated here in this slide here. So here we have the fetal situation to the left here, and if you go up, it's what happened if you defer cord clamping, or down here, immediate cord clamping. And what you see that is that the oxygen saturation increases slower. It starts slower and it increases slower if you practice immediate cord clamping. And I think this is very important. The upper blue line here is there are data from Max Vento's study, and the black line is from Dawson's curve. And you see that we probably need new nomograms after we have started practicing delayed cord clamping. Just one warning about cord milking. This is from Kateria's work. And what he showed was that there is a fourfold increase in severe intraventricular hemorrhage if you practice cord milking in immature babies. You see here the risk of severe intraventricular hemorrhage after cord milking in the black bars versus delayed cord clamping, the gray bars. So why does this happen? Well, if you milk the cord, you get an increased venous return to the right atrium. And this enters, of course, the foramen ovale and aorta. And due to lack of cerebral autoregulation, right to left ductal shunt, this results in fluctuations in flow to an immature brain with fragile germinal matrix. And this may trigger intraventricular hemorrhage. So this is maybe one way to illustrate that. A few words about chest compressions and use of adrenaline and what Lakshmin Rushma and his group has shown in animal. Do you hear me? I see that my connection is unstable. Do you hear me clearly?
You're okay now. You're okay now.
Yeah, okay, thanks. So what they found in animal studies was that even if they used the recommended dosage of epinephrine or adrenaline, 0.03 milligram per kilo, it's the flush volume which is of importance. So if you flush the epinephrine with only 1 milliliter, you achieve the spontaneous heart rate after first dose in 43%. If you flush with 3 ml per kilo, you get a double reestablishment of circulation in 89%. So I think this is an important clinical detail, that you should flush with a higher volume than previously applied, 3 ml instead of 1 ml. And what about oxygenation during chest compressions? Which FiO2 should be applied during chest compressions? And should FiO2 be weaned rapidly or gradually when reestablishment of circulation is achieved? Well, the American guidelines, NRP, they they state that it may be reasonable to increase inspired oxygen to 100% if there was no response to positive pressure ventilation with lower concentrations. And I support that statement. However, they also state that once return of spontaneous circulation is achieved, the supplemental oxygen concentration may be decreased to target a physiological level based on pulse oximetry to reduce the risks associated with hyperoxia. Well, I'm not sure this last statement is the optimal one, because again, if you go to Lakshmi and Rushma's group in Davis in US, what they found in newborn lamb and a newborn lamb model was that when they weaned FiO2 abruptly to air adjusted based on oxygen saturation, you prevented the surge in PO2, and it minimized the oxidative stress compared to a gradual weaning from 100% oxygen. And here we have the data, and you see the red squares here are from animals, and here we have the cerebral oxygen delivery on the y-axis. And you see that if you wean gradually, the red squares here, you overshoot this gray area, which is the recommended area you should aim at, the target at. You see it takes more than 15 minutes before you reach the target. By contrast, if you wean directly to air, you see that you're within this target within 1 minute. So I think that there's many reasons for doing that. So reducing FiO2 to air immediately. And then a few words about thermal control, heat loss prevention. And you all know that you should place or cover infants with an occlusive wrap immediately after birth if it's immature. And this will reduce the incidence of hypothermia and result in decreased morbidity and mortality, hopefully. But unfortunately, it's not like that. This is from a Cochrane review some years ago, 4 years ago, showed that there was absolute no difference in major brain injury, whether you put this baby, wrap them into plastic or not. And there was no difference in mortality. Still, we think that it is important to keep these babies thermal neutral, and I would still recommend to wrap them into plastic, but we have to know that it might not influence morbidity or mortality. By contrast, early kangaroo mother care is important. This study, which I'm sure all of you know, it's also taken Indian units took also part in this. Babies between 1 and 1.8 kilos, kangaroo mother care immediate show that it could lower mortality and also was good for early initiation of breastfeeding. I have to add, though, that the first time I visited Maulana Azad Medical College in Delhi in 1991, I think they practiced early kangaroo mother care already at that time, maybe without knowing it. And then I will end up with a few words about the HELIX trial, because I would like to discuss it with you and hear your opinion about it. And the HELIX trial was a study, as you know, where low to moderate babies above 36 weeks, more than 1.8 kilos, were treated with hypothermia. And you can see from here that in this study, they were very successful in separating the control and the hypothermia groups. You see the hypothermia babies, they got a temperature of 33.5, which was the target. But when they looked at the outcome, as you know, the secondary outcome, which was death up to until 18 months, this found that there was a higher mortality in hypothermia arm. And the relative risk ratio was 1.35, 42 versus 31%. And of course, and here is the Kaplan-Meier plot showing that babies treated with hypothermia, they die earlier, faster, and some higher mortality than those who did not get hypothermia therapy. And of course, this created a lot of discussion. And for instance, this review article here, Rise and Fall of Therapeutic Hypothermia in Low Resource Settings, lesson from the HELIX trial. And the authors stated that generation of high quality research data alone are not sufficient. It is important that low and middle income countries, clinicians have the necessary skills to interpret these data and use it in their clinical practice without being influenced by industry lobbying or stakeholders with vested interest. So this is a meta-analysis of all the data in low-income countries of cooling before the HELIX trial, and here you can see that there was an effect of cooling. So I would like to hear your opinion about that. So just to summarize very briefly, we published last year a study about delivery room management of asphyxiated term and near-term infants. And here we put a list of issues, variables, as cord clamping, basic steps of neonatal resuscitation, heart rate assessment, etc., etc. And we try to distinguish between low resources and high resources. So in low resources, we recommend delayed cord clamping, and high resources, immediate cord clamping to initiate resuscitation measures. I'm not sure I agree with this conclusion today, but this is how we put it then 1 year ago. And so for those who are interested, you can read this and find, see if you find anything of interest. And here are some references to the data I have shown you today, for those who are interested. And with this, I will thank you for your attention.
Thank you, Professor Saugstad. I don't think I need to elaborate till, so as the privilege of the chair, I'll save some of my personal questions to the end. I would like to open this to the audience, and if there are any queries, please pass it over and we can ask, because there have been many elegant points that he has dealt with. And if there are any queries, kindly come up with them. If I recollect correctly, sir, you had asked for the first comment from the House about auscultation instead of ECG monitoring. What is our opinion about this to determine the heart rate of a newborn baby in the delivery room? How many of you would be using ECG monitoring here? Would you please raise your hands? How many of you would be auscultating the babies here? I guess it's unanimous. Everybody here prefers auscultating. I personally feel, if I could comment, long time back, people came up with mandatory to do pulse oximetry saturation as soon as a baby is born. And we even specified the company from which the pulse oximeter should be obtained. And now suddenly that has come out of vogue, and I can assure you there have been a lot of money spent on that. I'm sure some monitoring will come up where some leads will stick very easily on the chest, and there'll be some company coming out with that also. And if it's recommended as a standard of care, I guess some people will be spending a lot of money to come up to the mark. And come back to your basics about air instead of oxygen. We'll also land up finally saying auscultation is the best, sir. I think we go with him. There's a more
Yeah.
practical interest.
Yeah, thank you. Because I think it's important. We shouldn't forget to do auscultation, and I think it should be the basic still, even if we get more sophisticated equipment.
The other comment I wanted to say was physiological cord clamping. A very good study has been done in India also by Dr. Mangal Bharati and team from Chennai, in which they utilize this, and I think they have come up with very good data in that. It's unfortunate that we are not able to give it much more international exposure for that pattern.
Yeah,
And they
I'm
have
sorry
found
for
it to
that.
be
Yeah.
useful.
Yeah, I'm sorry for that. Yeah.
Your last one is a favorite one for this house, that is Helix
Hmm.
trial.
Yeah.
Well, I have my personal opinion, but is there anybody here who would like to make comments? Welcome. I don't know why everybody is very diplomatic, which I am not. It has been one of the best rebuttals to this has been published in the Indian Journal of Pediatrics, I think in the previous edition of this year, by Professor Bhatt and Adisheshan from the Pondicherry group. And I agree with Sen person. In fact, I have some more objections to what has been said there, because while a study can be made statistically perfect, the fundamental error of sampling is there. When a sampling center is tested, it should always be tested on centers where mortality is otherwise the lowest. Because if you take it from centers where mortality due to many reasons is even otherwise high, your data will be so skewed that you will not know what is a contributory factor for this. There are very good centers in India which can at any day compete with any of the Western centers where they're doing cooling. And perhaps some of us felt that the centers chosen were based mainly on the MRI specificity of the center. Like, do you have the appropriate MRI scan available, rather than do you have the type of facility? It is not just level 3 care. Do you have the 1:1 nursing facility available? It is not just equipment. Most of the centers were government centers where we know that we are so flooded with patients and we can't turn away patients from India. So the choice of center is something which we felt was absolutely unjustified. It is also, I feel, extremely cruel to say that people had vested interests and industrial interests in this matter, where all of us know that the study work done with the Mira blanket that was done from Velo was totally free, honorary, and there is no incentives in that. And even WHO has said that it is one of the best innovations that has been done. So certain comments should definitely have been avoided. And this is far, far from being a recommendation. I feel perhaps this study could be also not told as from low and middle income countries, because most of the centers were from India. And with a few samples taken from 1 or 2 countries around the place, we are forgetting that this small group does not make entire low and middle income countries of the world. So I think it is an authentication of a study in this matter is something I feel publishing houses should refrain from making in future, because a lot of people still do continue cooling. Many people swear by it, but the center has to be good for it. And when the center is good, the results are good. So I don't think we should paint everything in this brush. That's my personal opinion, and not as a chair of the session. And as usual, I'm the least diplomatic of the group. I stand by my words.
Yeah, no, thank you. I was very interested to hear this. If I understand you correctly, you still think that you should cool these babies, provided you have the correct environment, you have the correct settings.
Yes, that's it.
Yeah, yeah, very valuable comment.
Yes. Dr. Arun is from New Zealand. He is one of our visiting faculty this year.
Yeah,
Come on.
and also a friend of Sabine as well as Tita. To be on their defense, I'm not saying that we shouldn't cool. In fact, I was one of the first to criticize them. I sent a personal email to them and said, no, this is not the right way to really even project these sort of things. And as you very rightly did that meta-analysis, you showed the meta-analysis that the benefit, even in low and middle income countries, is far exceeds the thing that Helix trial has shown. We didn't go by just one study, would you, for making a standard recommendation? I think we should go by, as we always have been saying in this whole evidence-based situation, that it is a systematic reviews and meta-analysis which should be the standard evidence-based rather than just one study. Or this has shown that there has to be caution, really, as the chair has already suggested, that unless you have a center with all the facilities which already outlined, there is no reason not to. It is unfair, and I brought this to their attention as well. I said, if you think the population that you're dealing with is absolutely different from the population of the Western world, why don't you do individual patient meta-analysis of those children from Asian countries who are born in the Western countries, from all the studies that we have done, and see if there is a difference? They haven't responded to me for that.
Okay.
Sorry, this was a long-winded comment, but I think we should be doing it.
Yeah, thank you. Thank you so much. I appreciate your comment.
I'm Gary Lettison from Chennai. So, in my opinion, basic reason why hypothermia did not work in this setting is because of inadequate intensive care. So when you look at the type of intensive care which these babies in all the centers they are giving, as Chair has pointed out, there is inadequate nursing care. And there are several other issues in the intensive care. So in pulmonary hypertension, in them was diagnosed based on clinical saturation. So this is not how we do in high income countries. Several other issues. So basically it is inadequate intensive care which is causing the problem, caused a problem. So in babies who are already sick, you are administering a therapy, hypothermia, which is going to destabilize. Those babies are going to deteriorate. So that's the main reason, in my opinion, why this baby didn't do well.
Yeah, thank you. Thank you. I know that Chennai was one of the centers participating.
Any other comments, please? I think very useful comments were made. First of all, I really enjoyed the one about the adrenaline, in which just increase the volume, which is something very practical for all of us can practice. And overall, one graph of yours, Professor Ola, was a bit confusing for me, in which you said that the cesarean sections, the infant mortality rate would be the lowest if it is around, should not be more than 20%. But somehow the graph, when it went below 10%, seemed to rise. Now that was a bit confusing. Does it mean that if you don't do cesarean sections and if it goes well below 10%, you may still have a higher mortality?
I think the mortality was according to this study by Yi, it was kind of stable after 10%. So, but I think before we draw conclusions, we have to add morbidity also. And of course, that C-section will reduce some morbidities, but it also may increase some morbidities. So it's a balance. And that's why I said my best guess is that the optimal C-section rate should be not higher than 20%. But I think it's an educated guess only.
Can it be lesser because your graph went up
when
it is less, let's say 8%?
Could be less. Yeah, it could be less.
We have found that sort of anathema for C-sections has been giving rise to a lot of things like Erb's palsy in our experience, where there is so much push of not doing cesarean sections that you land up with babies with an Erb's, which is quite worrying.
Yeah.
So this is also something which we are really concerned about.
Yeah. So what do you think would be the optimal C-section rate? I mean, in Norway, we try to keep it around 20, not about 20%.
No, 20 is fine. 20 is fine. But I think each obstetrician is trying to outdo the other by reducing the C-sections further.
Yeah. But I think it's a concern in many places in the world. C-section rate above 50%. And we, as neonatologists, we have to tell our colleagues and also the mothers that this is not optimal.
I think we have had an elaborate discussion, and Manoj would like to personally thank you for coming on. I'll hand over the mic to Manoj.
Oh,
Prof Ola, thank you so much, sir. It's an honor to have you here for the second anniversary of our sessions, which we began with you. If you remember,
Yeah.
2 years ago, we inaugurated the Learn from the Legends session with the talk on oxygenation of newborn. It was we were chartering in unknown waters at that time, but then now we are so thankful to you. Only thing we are missing your physical presence here. That is something, because of the continuous postponement. Anyway, we hope to have you here in Kerala in the near future.
thank you so much, Manu. Thank you for these kind words. And I really hope and look forward to visit you in Kerala soon.
Thank you, sir. Thank you so much.
Thank you.
Thank you. Thank you so much. Thank you all.
Thank you, Diwakar, sir.